Thank you. I want to thank you, the organizers, for inviting me. And I appreciate the idea of having a reception after this, because I know the idea of a free glass of wine is keeping some of you here. I do feel a little like a fish out of water because I'm not an expert in biomarker evaluation and targeted therapy or oncology trials. I work primarily in the interface between observational studies and prevention trials. So it's been a crash course today for me and some of the issues in oncology trials. And I want to thank the previous speakers who've done a really fabulous job of covering a variety of issues. I took this opportunity to review some of the statistical literature on this topic. And there are several groups that are working on the design and analysis of therapeutic trials for targeted therapy. And they tend to come from different perspectives. There are those who are looking to determine the best way to evaluate a new targeted therapy. There are those who are looking to examine existing treatments and can we identify which patients are most likely to benefit versus those who may not benefit from those therapies. Then there are those who are focusing on the biomarker test itself and how do we discover, validate, and identify the clinical utility of those. And the design analyses are all tailored to those specific questions. They're all very somewhat different, but there are a couple of common features. And one is that all the statistical literature do start with a randomized trial. And this is not because statisticians are fundamentally lazy, though we may be. It is because there's sufficient unexplained variability in patient response that we need a real comparison group to actually validate the value of a new approach. And the randomization provides the simplest way to do that. Another common feature is that each of these tests is really based on an interaction test at some level. So I want to, let's see if I can describe that. Take a very simple case where we have an existing trial comparing two treatments, and we want to identify the patients who would be most likely to benefit from treatment A versus treatment B. So if a new biomarker is identified to try to do that, we might measure it retrospectively if we have specimens available and classify the patients in both treatment A and treatment B according to their biomarker status. Now here I've chosen a very simple biomarker, which is clearly positive and clearly negative. I'm not including any measurement error or any of the gray space that might exist here. And so the question is, we want to look at delta 1, which is the difference in the patient outcome for those who are biomarker positive on treatment A versus treatment B, and delta 0, which is the difference in patient outcomes for those who are biomarker negative. So given delta 1 and delta 0, the primary analysis is this interaction test. Does the treatment effect differ between the two biomarker groups? Does delta 1 equal delta 0? And that's the question we're asking. If those two are equal, that implies there's no added value of a biomarker-guided treatment. This could be either that the test was not effective in identifying the patients who would likely to benefit, or the treatment itself was equally efficacious or equally inefficacious in both biomarker groups. So there's some literature that's starting to grow that says this interaction test is necessary, but it's not sufficient for evaluating the marker performance in this setting. But I'm not going to delve into that any further. I would like to note that we've heard today a few scenarios where we would say delta naught is really not of interest. We're really only interested in those who test positive for this marker. And so that's essentially saying we're willing to assume delta 0 is 0. There's no treatment difference there, and we're fine with that. And there are certainly cases where that's a reasonable assumption, but then we're giving up learning anything about the effect of that treatment in the biomarker negative group. So when we do this biomarker evaluation in an existing randomized trial database, what we're doing really is a subgroup analysis. And we've been doing those in clinical trials for decades. We typically have been looking at this variation by many patient characteristics and clinical characteristics and a few limited tumor characteristics. But now we're in the position where we have a multitude of tumor characteristics to think about. And that's a challenge for us as statisticians. I would note that there was a nice article in 2007 in the New England Journal giving us the cautions about interpreting these subgroup analyses. One, these subgroup analyses tend to inflate our type 1 error, our probability of finding a difference when in fact there isn't one, just a chance finding. And these subgroup analyses are typically doubly cursed, and that is they tend to inflate the type 2 analyses as well. That is, they tend to miss true differences that are there because they were not considered in the original design to have adequate power. Nevertheless, they can lead to hints, to ideas that might guide for further research, and so they're important to do. The problem in many of these existing randomized trials that weren't designed originally to look at these biomarkers is that we often don't have access or can't get access to these specimens, and we have to worry about the quality of the assays, especially when done in archival specimens. So often we won't have a randomized trial to piggyback on. So the question then becomes, can we use other non-randomized databases or registries to evaluate these targeted therapies? And the underlying questions to this is really, what is the reliability of inference from observational or non-randomized studies? And what is needed from an observational study to assure this reliable inference, assuming that it's possible? So rarely has the concordance between randomized and non-randomized studies been examined in a systematic way, although I believe the NCI's move away from single-arm phase 2 studies suggests that they believe that single-arm studies or non-comparative studies are not as reliable as we would like. And I'm going to drag you for a minute into my world where we have done a very systematic look at a randomized trial versus an observational study to try to understand where they differ and how we can try to explain those differences. So I'm taking you to women's health, postmenopausal hormone therapy. The estrogen use was approved by the FDA in the 1940s for relief of menopausal symptoms, and the ads might suggest other reasons too. Its use became, I should say, was not based on any randomized trial evidence, purely observational studies. And it was and still is the most effective way to deal with hot flashes, except maybe taking off my jacket. Their use became very popular, but it peaked in 1975 at about 30 million prescriptions a year because of an observational study, a case control study, or several that showed that estrogen use in women with an intact uterus had a very elevated risk of endometrial cancer, a 5 to 8-fold increased risk. So over the next 5 years, use declined by about 50%, until in the early 80s, it was determined that adding progestin to estrogen would help to protect the uterus. So use again began to rise, now in 2 different forms, estrogen alone and estrogen plus progestin. This was great fodder for epidemiologists. Millions of women taking them, they can do lots of observational studies to look at the health effects of these medications. And so observational studies found beneficial effects on bone density, and the FDA approved an indication for osteoporosis treatment and prevention. Other observational studies showed benefits for cardiovascular disease risk factors. So then in one issue of the New England Journal in 1985, there were 2 back-to-back articles published, one by the famous Framingham Heart Study on estrogen use and cardiovascular morbidity, and the other one by the equally famous Nurses' Health Study. The Framingham study, you don't need to read that, but it was looking at over 1,200 postmenopausal women. that they had followed prospectively, and what they found was that women reporting postmenopausal estrogen use at one or more exams had over a 50% elevated risk of cardiovascular morbidity with a p less than 0.01, and more than a twofold risk for cerebral vascular disease. And they concluded, they said, no benefits from estrogen use were observed in the study group. In particular, mortality from all causes and from cardiovascular disease did not differ for estrogen users and non-users. So then the next article was the Nurses' Health Study. And they looked at a subcohort of 32,000 postmenopausal women who were initially free of coronary heart disease. And they found the age-adjusted relative risk of coronary disease in those who had ever used postmenopausal hormones was 0.5, or 50% reduction in risk, with a p-value of 0.07, and the risk in current users was 0.3, so a more powerful effect in the current users with a p-value of 0.01. And their conclusion is these data support the hypothesis that postmenopausal use of estrogen reduces the risk of severe coronary heart disease. So it was 8 more years before a randomized trial could be launched to resolve that issue. These were 2 really well done observational studies, large sample sizes, excellent follow-up rates, treatment assessed at multiple time points, strong clinical outcomes, and each found statistically significant, really pretty good effect sizes, but in opposite directions. What are you going to do with that? Well, what did the clinical practice do? What did the literature do? It followed the positive results. I think that's our inclination as humans, to follow the positive things. So use increased a lot, driven by the osteoporosis indication, but the coronary heart disease results were also played a part in this factor, in this. So in 1993, the WHI randomized trials of hormone therapy was finally launched. It was actually 2 parallel trials testing Premarin, the most commonly used hormone therapy, and actually the best-selling brand name prescription drug in 1992, with over 37 million prescriptions. So we compared Premarin versus placebo in women with prior hysterectomy, and Prem-Pro, which is their combination, estrogen plus progestin versus placebo, in over 16,000 women with an intact uterus. This was a challenging study to launch because of the prior observational studies that suggested really strong benefit. In fact, we were called unethical for doing this, and an IOM study commissioned to review this early on asked for a 6-year review point. The trial was to be 9 years. They asked for an early termination point at 6 years so that we would not be denying benefits to the women on placebo for too long. So if you know anything about that study, you know these results that came out in 2002. Both trials were stopped early, but the estrogen plus progestin trial, the catalyst for stopping was the 26% increase in breast cancer. But equally troubling was the increase, the 29% increase in CHD, the 40% increase in stroke, and the over doubling of blood clot rates. So this was a problem both for the clinical research, clinicians, and for researchers to try to understand why the observational studies were so far out of line with this clinical trial. We were in a unique position in the WHI, though, because in recruiting the 27,000 women for the hormone trials, we also recruited into an observational study. Over 93,000 women participated with similar baseline data collection and almost identical follow-up. So we have parallel information on women who were treated according to clinical practice. So in a series of articles led by my colleague Ross Prentice, he actually performed the natural experiment in the observational study in parallel to the clinical trial, and jointly analyzed these to try to understand the differences between them. So taking the database and looking at all those women who would have been eligible for the estrogen plus progestin trial, but who didn't consent, either because they were already using hormones and didn't want to give them up, or because they weren't using any and refused to be randomized to active. There are 17,000 hormone users at baseline and 35,000 non-users at baseline who had an intact uterus. And so he analyzed these in an intention to treat type analysis, which is not common in an observational study, but is done to more mimic the clinical trial. And for CHD, what did we see? Well, in simple age-adjusted relative rates in the red, I'm sorry, the numbers aren't accurate, but the size of the events here are, the relative risk was elevated in the clinical trial in red, but in the observational study, we saw a 30% reduction in relative risk for CHD. So this is consistent with all the previous observational studies. We didn't do any better by doing the observational study in this prospective fashion. By doing a multivariate adjustment for all the potential confounders of hormone use, it explained about 20% of the bias, but the effect sizes are still going in the opposite direction. It was not until we took into account the insights we gained from actually doing the trial, which were time-dependent effects. There was a large adverse effect in the first 2 years of taking hormones, followed by a reduction in risk and maybe actual benefit if you survived for 5 years. That we could, doing the same analysis in the observational study, we started to see that same pattern. And while the magnitude of these effects look quite different, you can see these numbers are correct. Those are the number of events in the active treatment arms. The confidence intervals are very wide, and there's actually statistically no residual bias between the clinical trial and the observational study. The same kind of modeling worked for blood clots, where we had a very large impact in the clinical trial, and the observational studies showed essentially nothing. Multivariate adjustment controlled for only part of that, but the time-dependent analysis showing these time-dependent effects really explained the difference between the two study designs. A similar approach was somewhat helpful for stroke, but didn't totally explain all the differences, as not all of these bars are lining up on the same side. I won't take you through all the data, but essentially the same pattern of alignment occurred for the estrogen alone trial for the cardiovascular disease endpoints, but for breast cancer, other factors had to be taken into account. In particular, we had to look at modeling by time since menopause from first use, and importantly, we had to restrict the analysis to women who were getting regular mammograms, since mammograms would change the time of diagnosis, and women who get hormone therapy are more likely plugged into the healthcare system and get regular mammograms. So a few reflections on this experience. These observational studies obviously can have a profound effect on clinical practice and thereby on health outcomes. In most cases here, it was possible to align the randomized trials with the observational study results. Although it was not straightforward, and we were criticized by many about whether this was actually the unique and only way to align the results, or whether another set of statisticians would have found some other explanation. In our hands, the alignment depended on really creating this natural experiment within the observational study, which means applying the same eligibility criteria, having parallel, very high quality follow-up, and the use of this pseudo-intention to treat analysis paradigm. And also in capturing the noteworthy potential confounders of treatment assignment. And finally, it was analyses of the randomized trial itself were really influential in explaining some of these discrepancies, and it's not clear to me that we would have ever figured that out, about the early adverse effects, without the insights gained from this trial and the previous HERS trial. So what do we take away from this for evaluating other therapies in an observational setting? Well, I think it's safe to say that if you want to make it simpler, more similar to a randomized trial, then the observational study should emulate the randomized trial you'd like to do, but can't, perhaps. You can say Miguel Hernan from Harvard has done this and taken it to the next step in a even more sophisticated approach, simulating multiple clinical trials within the Nurses' Health Study, and was able to align that study, which was so different than our clinical trial, by doing this. The importance of the specific elements may differ from this particular example. In the therapeutic setting, it's not clear to me that the potential confounders are the same. Maybe it's not BMI and physical activity and smoking. Maybe here it's more factors related to choice of treatment. Does a person accept the targeted treatment or are there comorbidities that need to be considered, things like that. But those still need to be captured. Time-dependent effects may or may not be the issue. I'm not close enough to the settings that you're dealing with to know. But I can say that the supportive care and the surveillance mechanisms are likely to be important. We know that patient prognosis can be really affected by supportive care, and especially for soft endpoints, the surveillance mechanisms could change the timing of outcomes. And so you need to have equal surveillance protocols in the observational studies. And the modeling may be outcome specific. So, and I'd also like to say that these approaches are most valuable when the database captures all the relevant outcomes. The effort needed to control potential bias depends on the underlying effect size. So if you really have a home run, maybe you don't need to go to all this effort. But the more modest effects, 20, 30, 40% changes in event rates, can easily be masked or lost through the confounding or other issues that can exist in an observational study. We also need high quality repositories with broad consent to assure that you can assay all these biomarkers, which are then needed for the interaction tests. I want to say that interaction tests in the observational studies can suffer from the very same concerns that we see in the randomized trials. The potential benefits for the observational setting, they can enhance our inference by capturing a larger and perhaps broader study population and a larger range of therapies. And they can facilitate rapid evaluation of new biomarkers, potentially at a lower cost. But I feel like it's important to say that all of these would be enhanced, if possible, by a companion randomized trial. So I was asked to say a bit about who should build, maintain, have access to, and fund database registry efforts. And not being very close to this issue, I kind of feel like it's a hot potato for me. So my thoughts are, I've heard today and know of many high-quality resources that have part of the picture that one needs for this. And I think it's really in our best interest to leverage these as much as possible. It may be my own bias as well, that I think academic settings are the better place to develop these resources when we're so early on in this process, based on fewer conflicts of interest, clear oversight mechanisms, and a more open access. And any resources needed to be developed de novo, I think would benefit by having randomized trials at their core, or at least as their intent. But we need more work by the statisticians for novel trial designs that start to address the multiplicities that we're dealing with here. I'd like to thank a few of my colleagues at the Hutch who've been influential in my thinking. Thank you for your attention.